All right, welcome to another episode of my Fertility Podcast, Superhumans. And today we are finally recording our first of many episodes about the immune system and fertility. This is a topic that you have asked for again and again and again. And I promise you, Dr. Wise and I have had sleepless nights and a lot of conversations and a lot of anxiety about recording these episodes. But ultimately, we trust you. We trust that we can speak honestly to you, that we can tell you about the limitations of testing, that we can explain why sometimes we don't test even though you asked us to. And you deserve this information as hard as it is for us to do it. You deserve to hear it. You deserve to understand it. And we really hope that after these 4 or 5 episodes on the immune testing, you're going to have some clarity or some understanding about how, as fertility specialists, people devoted to helping you conceive, wanting you to succeed, how we think about the testing and treatment in fertility related situations.
Yes, these have been very, very difficult episodes to frame in our minds and to tackle them and to write these scripts because they're really complex and we recognize that they're extremely controversial amongst the field of fertility specialists and reproductive endocrinologists. And I think we really need to start by explaining why it's controversial, calling out the elephant in the room, I guess, and recognizing the fact that very few fertility clinics, especially in Canada, actually offer this type of testing and treatment, and why that is.
So, the first challenge is recognizing that the immune factors that play a role in pregnancy and miscarriages are very poorly understood. There is no question in the world of fertility, in the mind of fertility specialists, that the immune system plays a really big role in reproduction. However, the exact way in which that role is played or the exact mechanisms in which the immune system impacts implantation and pregnancy loss, those exact mechanisms are not clearly understood.
Mm-hmm. I mean, this stuff is the stuff that fertility doctors are debating at conferences. There's going to be something around the immune system and people debating how important it is, what's not important, what to do about it. And so basically, that really leaves you as the patient and your physician, and frankly, all of us as physicians, looking for practical answers to really complex reproductive problems. And then also trying to make the best decisions possible for your specific case with a really limited amount of data or an experience that we can kind of fall back on. If you are someone who is experiencing recurrent implantation failure or recurrent pregnancy loss, recurrent miscarriages, after everything else has been done, it's really hard to just kind of keep doing the same thing again and again and expecting a different result. And we absolutely recognize that.
At Michael Fertility Center, we have been doing immune testing and treatment for many, many years. Dr. Vero, who is now retired, has been using immune treatment since about the year 2000, and we have seen referrals from all over the world for this kind of testing and treatment.
First of all, what we want to say is that, if you're at a different fertility clinic and if you're seeing a fertility doctor who has maybe not offered you immune testing or treatment or who hasn't even really discussed immune testing or treatment with you, they're not a bad doctor. We want to be super clear about that. It's not that they don't care or that they're trying to hide things from you because, they want you to do more IVFs or something like that. These treatments we recognize are really not considered standard of care and they're not standard therapies. And they are not routinely offered at every fertility clinic. And really, there's only a few physicians in Canada that actually specialize in these treatments and have a lot of experience with them.
Now, with that being said, let's break down this first part. We're talking about how we approach immune testing and treatments, or MFC specifically. We're going to talk about what kind of tests we do, how we counsel, and how we select patients for testing, as well as some of the costs of immune testing and some of the treatments that we may offer.
In subsequent episodes, we're going to dive into specific treatments and specific tests that we might do. So we're going to talk about IVIG or SCIG or SCIG. We're going to do a separate episode on LIT or LIT, and we're going to do an episode on treatments to modify cytokines, including intralipids, and we're going to do an episode looking at other immune modulating medications as well. But let's get started at the very beginning, where we're going to talk about the immune system in general.
So, yeah, what is the immune system exactly? Well, the immune system is your body's natural defense mechanism. It protects against pathogens like bacteria, viruses, and even cancer cells. But it is not just a blunt force tool, it's a highly nuanced machinery with checks and balances between pro inflammatory and anti inflammatory responses.
Exactly. You can't just sort of do all the anti-inflammatory stuff and just nerf the entire immune system and expect pregnancies to succeed. That is a really, really important point where I think inflammation gets a bit of a bad reputation.
Exactly. The immune system have both innate immunity, which is the body's first response, like natural killer cells and macrophages, and adaptive immunity, which is a slower, more specialized response that involves the T cells and B cells. And together, they maintain a balance between tolerance, which is allowing certain things to get through, and defense from viruses and pathogens, etc. And when it comes to reproduction, that balance is really critical.
So let's talk about implantation here. When we're talking about the implantation of an embryo into the uterine wall, and when we're talking about early pregnancy, one of the most fascinating and really underappreciated things is how big of a deal the immune system plays in all of this. Yes, there's hormones and anatomy and all of that, but it's really largely about the immune system. The immune system has to learn to accept something that is, genetically speaking, foreign, quote unquote, to the person who is carrying the pregnancy.
The embryo is what we call semi allogenic. It means it carries both maternal and paternal DNA. Normally, the immune system is designed to attack anything that is foreign, but in pregnancy, it has to actually tolerate something that is foreign, the embryo. And it has to walk this fine line in tolerating the embryo, which is foreign, but at the same time, not losing the ability to protect the person carrying the pregnancy from real pathogens and infections.
Really, that immune adaptation actually starts even before implantation occurs. So, when sperm, seminal fluid are introduced into the reproductive tract, they don't just deliver genetic material. They'll also carry some paternal antigens or foreign antigens that essentially, quote unquote, introduce foreign DNA to the immune system of the person who's going to carry the pregnancy.
Exactly. And that exposure helps prime the immune system, leading to an increase in regulatory T cells in the endometrium. And these T regulatory T cells are peacekeepers. Their role is to calm down the immune system locally so that when the embryo arrives, the body is ready to welcome the embryo instead of attacking it, understanding that it contains foreign genetic material.
Then, when we talk about this window of implantation or that time when the endometrium is most quote unquote sticky to an embryo, the endometrium really becomes an immune hotspot. So you'll see specialized immune cells like uterine natural killer cells, macrophages, and again, more of these Tregs as we talked about.
And despite this terrible name of uterine natural killer cells, they actually aren't there to kill the embryo, quite the opposite. They help the embryo outer cells of the trophoblast invade just enough into the uterine lining and remodel the blood vessels so that there is a good blood supply developed for the placenta. Macrophages also play a role in tissue remodeling and clearing debris while the T regulatory cells continue to suppress any aggressive immune responses.
Now, the embryo, for its part in all of this, is not passive in this process. The embryo sends out signals. One of the best known is probably HCG, or the human chorionic gonadotropin, or the pregnancy hormone. That's the same hormone that we're measuring when it comes to a pregnancy test. HCG doesn't just signal pregnancy, it also helps shift the immune system towards a more tolerant state. And it will actually boost that T regulatory cell functioning and help support this very delicate balance.
And that balance is absolutely key. You need a little bit of controlled inflammation to get the implantation started, but not too much inflammation and not enough downregulation that can lead to problems like failed implantation, early miscarriage, or even complications later in pregnancy.
Mhm. The real magic happens in this crosstalk that's constantly going on between the embryo, immune cells, and the cells of the uterine lining, or what we call decidual stromal cells. If that communication breaks down, say, if the T regulatory cells are not induced properly, or if the uterine natural killer cells aren't functioning the way that they should, or the inflammatory signals are off, or something like that, the whole process can fail.
Which is why reproductive immunology is such an important field of study, although still is very controversial. We're only really beginning to appreciate how much these immune interactions determine whether or not a pregnancy will succeed.
Okay, so what is the field of reproductive immunology? Now, maybe on social media and stuff, you've heard people call themselves reproductive immunologists. So, what is that?
Yeah, so reproductive immunology is the study of how the immune system dysregulation can impact pregnancy and fertility. It's not really a specialty that exists in isolation. It is usually a cross section of immunology, obstetrics, and reproductive endocrinology.
And it'll include both innate and adaptive immune pathways. And it looks at how conditions like autoimmunity and inflammation or alloimmune intolerance can contribute to implantation failure or loss.
So, with that being said, let's talk about exactly what is this immune testing and treatment. Let me clarify something important here. Immune testing is not an isolated test, it is a panel of tests. And there isn't a standard panel when it comes to immune testing, but here at Markham Fertility Center, we do three types of testing. One is the autoimmune profiling, so that's looking at the lymphocyte antibody detection test, or LADs. We look for cellular immunity, which is divided into natural killer cells in the blood, as well as the cytokine ratio, the Th1 to Th2 ratio in the blood as well.
And immune treatments here at MFC can range from anything like low dose steroids, like oral medications, using immunoglobulin therapy, giving intralipids, using other medications like TNF alpha blockers, low molecular weight heparin, and even tacrolimus sometimes. Each will have specific indications, risks, costs, and again, we are using them in response to somebody's immune testing. So just because something is used for one patient doesn't mean that we're using it for all patients.
And we've said this before, but I'm going to say it again. These treatments are not the standard of care. They're considered experimental or adjunctive in most guidelines because the quality of the evidence is still very variable and controversial.
We've sort of alluded to this a few times, but I think it's important to get into the guts of this. Like, why isn't this immune workup, immune testing, why is it not the standard of care? Why is that, Dr. Garcia?
There's a couple of reasons for that. The first reason is that there is lack of high quality evidence. Now, getting good evidence in medicine is not easy, especially when you're treating humans, who are spending a lot of money into fertility treatments. Anybody listening to this episode who has gone through fertility understands that many people don't have 9, 10 euploid embryos that you can participate in studies with. And therefore, getting really good quality evidence is extremely difficult. So the quality of evidence is not great. The studies are small, they're observational, and they don't have big power because it's very hard to have a high number of couples that have similar situation in order to be able to really study an intervention.
Another big issue when it comes to really determining the pros and the cons of immune treatment is that the causality is really, really hard to establish. So in any study in the world of medicine, you can do a study and show that two things are associated, but it's really hard to prove that one thing causes another thing. And I mean, there are countless examples of this throughout medicine. and certain controversies that are coming up more and more that you may be hearing about in the news, apart from immune, but in the world of medicine. And in fact, we know that there's many immune abnormalities can be found in patients who may have no fertility issues and who do not have difficulties getting pregnant or recurrent miscarriages, which again makes it really difficult to prove that one thing specifically causes another.
And because of all of this, there is no consensus. So different clinics, different specialists interpret the same findings in different ways. And when there is lack of consensus across the field, then it makes it very difficult for guidelines to be put together and for anything to be considered standard of care, because it's very hard to get everybody to agree on something when the interpretation of things really varies so much between experts.
All right. So, another big question is which patients should really be thinking about, or which patients are we thinking about talking about immune testing, potentially immune treatment, right? Now, we have previously recorded 2 episodes on the topic of recurrent implantation failure. If you want more information,
You can check out episodes 72 and 76, where we talked about
even the definition of RIF is really not clear and still hotly debated whether it even exists.
We reference a famous study from 2024 published in Fertility and Sterility that followed patients that failed 3 euploid embryo transfers and found that the pregnancy rate for euploid embryo transfer number 4 and euploid embryo transfer number 5 was the same as people who got pregnant with their first and second euploid embryo transfer, which showed that after 5 euploid embryo transfers, the cumulative pregnancy rate was 98%. The authors of the study concluded that recurrent implantation failure technically doesn't exist, and it is a question of transferring enough embryos. And ultimately, the lack of success from an embryo transfer is related to an embryo itself, not necessarily to all the other things like the immune system.
At this point, I think it's important to state again that guidelines that look at recurrent implantation failure, in those episodes we talked about the Canadian Fertility Andrology Society guidelines on recurrent implantation failure from 2020. They really discourage the use of most adjunctive treatments and testing, including immune testing and treatment. And really, when you read the guidelines, the general recommendation is basically to just continue transferring good quality embryos with the idea that eventually it's probably going to work.
However, welcome to the real world. This is where science and studies and medicine meets the patient in front of you who maybe has total 3 euploid embryos, maybe total 4 euploid embryos, who has failed 2 euploid embryos, who has done everything in their power to conceive, from taking all the vitamins and the supplements, changing the lifestyle, following the protocols to the T, and they are still not successful. They are terrified that the next embryo transfer is not going to work because we're not changing anything, and they are pleading, rightly so, and asking, doctor, please, what else can we do? What else can we do? And that's the real world that we all live in. And as physicians, we all feel this responsibility to have discussion with these patients about different testing and treatment options that might not be the standard of care, but they're there. And they might be the right set of testing for people in that situation. So even though the guidelines would not recommend, I think it's fair to have an honest discussion with our patients that have failed euploid embryo transfers before continuing to transfer more embryos, because at the end of the day, we really believe, especially here at Marketing Fertility Center, that every case is unique. Every patient deserves to have that conversation and to have their treatment individualized to their clinical situation, but also to their own personal preferences and values.
It's also worth noting that even outside of immune testing and treatment, there are many things that we do in the field of fertility that are maybe not necessarily evidence-based or not necessarily guideline-based, not because they don't work or because they're quote unquote bad, but because we just don't have the evidence yet. So, our knowledge right now may be limited, but again, if we have those good quality studies, or maybe a few years down the road, we may look at things very, very differently as well. And again, in that same study that we referenced, we said 98% of people got pregnant. Well, there's this 2% that probably really have true recurrent implantation failures. So, again, when we talked in those episodes about RIF, we said we recognize those 2% of people and that RIF, we think, is a real thing. It's rare, for sure. It's absolutely rare, but that sometimes you get to a point where you do need to start thinking outside the box. And that's the difference between writing a guideline and the real world and actually seeing those patients in front of you.
So, with this in mind, we do have a discussion with patients with full transparency about the limitations of the current research and, again, what the guidelines are saying. So, we would often start this discussion after one failed UPRO embryo, but we don't think that one failed UPRO embryo transfer requires you, or we actually don't recommend that we do immune testing, but we introduce it, we start the discussion. We say that we would start more actively recommending immune testing once there have been 2 or 3 high quality euploid embryos that have been implanted. Of course, assuming that we rule out everything else about uterine factors and endometrial lining factors. And when there is recurrent pregnancy losses, 3 early miscarriages, again, after we have ruled out any anatomical, genetic, or endocrine factors that can also lead to pregnancy loss. Speaking of pregnancy loss, we had 2 episodes that we go into detail about recurrent pregnancy loss, and this would be episode 51 and 56.
We get asked about immune testing a lot. We have many patients who see us specifically to talk about exactly that. Maybe they've been at other clinics where they have failed euploid embryo transfers, or at least very good quality embryo transfers. Or maybe they know somebody who has failed euploid embryo transfers and they want to prevent being in that situation. So they feel like if they do this earlier rather than later in the process, that they're somehow going to get ahead of this so that they're not going to be affected by it. And listen, we absolutely get it. Emotionally, one loss, one failure is one too many. And we know patients would do anything not to go through that again. But our current understanding of the science of implantation and the immune system is really rudimentary at best. And so, from the patient's perspective, we really do not have clear answers to these problems. And we recognize that it's incredibly frustrating. I mean, it's incredibly frustrating for patients, and it's also incredibly frustrating for us too as fertility doctors. You know, giving the advice of let's try again, or let's do another transfer, or it was quote unquote bad luck, or it was because of the embryo, but we really don't know why. And we recognize that this can feel dismissive and it can feel invalidating. On the flip side, though, it's also worth noting that reproductive medicine and medicine as a whole, it's not like a drive through window, right? It's not like you can order whatever tests you want. And let's say we just go ahead and do them. Our role as clinicians is to help patients select the right treatments for the right person in the right circumstances at the right time, and with ample discussion about the evidence or lack thereof in many cases, as well as the financial costs and time costs. It's very important to point that out because, again, there are financial costs to many of these things. There's also costs of time in terms of delay to proceeding with the next transfer. Doing this stuff, there can also be very real risks to some of these treatments. Risk to the person carrying the pregnancy, whose immune system we might be trying to modulate in some way. And there may also potentially be some risk to the pregnancy itself. You know, doing more testing, doing more treatments does not necessarily guarantee that there's no potential harm. And then, of course, we're also sort of thinking about setting of expectations again and sort of the costs and emotional toll that that can take too. Even if we do all the things and we make the immune system as quote unquote perfect as possible, as perfect as we know how to make it, we still need an embryo that has the ability to lead to a successful pregnancy. And so, even when the immune system is perfect and all the test results come back quote unquote perfect, that pregnancy rate never gets to 100% per transfer. Unfortunately, it's probably still going to max out at about that same 65 to 70% mark.
So, with that being said, let's talk about what immune testing looks like at Markham Fertility Center. At our clinic, immune testing starts by having a consultation with one of our fertility specialists, exactly like Dr. Weiss mentioned. We would review your history, listen to your concerns, and help you understand if immune testing is right for you or not, as well as what are the chances that it's going to change your outcome, what are the risks, what are going to be the costs. We discussed the criteria that we talked about before of having had failed euploid embryo transfers, as well as the ability to transfer more embryos if we are able to do immune testing and fix the immune system for an embryo transfer. We are transparent about what's investigational and about what's established and about whether or not you're a good candidate or not.
At the end of the day, it's really about that, exactly that. It's that shared decision making in terms of trying to decide how to move forward and what to do going forward. I would venture to say we almost spend as much time talking people out of doing immune
That's right.
testing as we do talking about doing immune testing, only because we are very honest and forthcoming. And we very much recognize that this is not the standard of care and it is not in the guidelines.
So, what are some of the costs associated with immune testing? A typical immune panel, which I talked about, it includes the LAD, natural killer cells, and the cytokine levels, costs approximately $1,500. The testing involves taking a blood sample from both partners, and this is the case even if we're using donor eggs or donor sperm. Testing can be arranged Monday, Tuesdays, and Wednesdays at Markham Fertility Center. The blood samples get sent to the US, to the Rosalind Franklin University for testing, and results are typically available in 2 weeks' time. At this time, you would meet with your fertility specialist to discuss the results of the testing, as well as plan for immune treatment and eventually embryo transfer.
When people are starting out on the immune treatment pathway, I always sort of will tell people as well, yes, that you're going to get your results in 2 weeks, but generally most people are not doing another transfer for somewhere between, 3 to 4, 5, 6 months down the road before we're actually doing an embryo transfer. And that's something really important to keep in mind.
Yeah, that's a great point. It's 2 weeks to get the results, but then it takes time to do the treatment before another embryo transfer. Absolutely. So now let's talk about some common pitfalls that come with this concept of doing immune testing in recurrent implantation failure or recurrent pregnancy loss. So one of the common pitfalls would be over-testing. Without a good clinical indication, for example, if people who want to do it when they've only failed one euploid embryo transfer or when they have failed IUIs and haven't even done IVF with genetic testing yet, it is very likely that in this scenario, you're increasing the cost of the treatment, you're increasing the potential risk, you're increasing time to pregnancy without really improving your pregnancy rate at the end.
And another thing that we will often encounter, and we talk about with patients, is that doing immune testing and treatment when you don't have euploid or at least very good quality embryos available can be an issue.
Can
for
backfire,
sure.
yeah.
Can absolutely backfire. So we really do not offer immune testing and treatment to patients who want to do more IUI or who want to conceive spontaneously. And the reason for that is multifold. So number one, we know that patients, even in the best case scenario, that pregnancy rate with IUI is going to max out at 15 to 20% per cycle. So when you do an IUI, let's say with immune treatment, and it doesn't work, you have no idea why or how to tease that apart. Was it the IUI? Was it the immune treatment that wasn't appropriate? You really cannot kind of go anywhere from that or learn anything. And the other thing is that immune treatments come with costs, come with time obligations. And so you can't just keep doing them month after month after month after month like you may with an IUI. Thirdly, as we said before, the overarching reason why somebody doesn't get pregnant is still often a function of the embryo itself. So either the egg or the sperm or how they came together, it's often number one factor being the embryo. When we're doing an embryo transfer, we have a lot more information about the embryo. We have a lot more confidence that the embryo will work, especially when it's a euploid embryo. And again, all of our protocols have been developed over the years for embryo transfer specifically.
Yeah, exactly. So, for example, if we have elevated cytokine levels and we're treating it with intralipid or SCIG, which we're going to talk in detail in future episodes, those are treatments that are timed to when the embryo is being transferred. So, it's very specific. It's not like a prescription that you take for 2 weeks and that's it, you take it and you're
Yeah.
treated. It's something that you are timing with the embryo transfer. And if we don't have an embryo to transfer, then yes, you can do the testing, but we can treat with intralipid or with subcutaneous immunoglobulin just randomly without having a specific embryo transfer event associated with it. Which also brings me to one of the reasons why we don't recommend immune testing and treatment for patients that have embryos at another clinic. That would lead to one doctor doing immune treatment, another doctor doing embryo transfer. The coordination between clinics is very difficult. We're really afraid that it's going to ultimately impact the patient's outcome when you have too many physicians or two different clinics trying to do the same thing. And again, immune testing and treatment, it's not something that is isolated from the embryo transfer event, which is why we really need to treat all the things together: your embryo transfer protocol, decisions about the lining, decisions about what embryo to put in, and at the same time, add the immune protocols based on the immune testing to that embryo transfer protocol.
With immune therapies, we always are very conscious or very aware of this risk of giving false hope. Immune therapies, they're not cures, they're not fix-alls, they're not magic. At the end of the day, the outcome of an embryo transfer is still going to depend really heavily on the embryo quality. What's the grading of the embryo? Is it a genetically tested embryo or not? How did the embryo look after it was thawed, for instance? What did it get to blastocyst stage on day 5, or was it a day 7 embryo? Those are still things that are overwhelmingly important. We also know that uterine factors play a role, age can play a role, and there's so many other things. So, yes, immune treatment and immune testing is another piece. It's another tool in our toolbox of things that we can use, but it is not the fix-all for everything else.
Yeah, you're absolutely right. And this is actually something that keeps me up at night when it comes to immune testing, because I see it all the time. People are really looking for that one answer, for that one cure, that one solution. And yes, in a right situation, we offer immune testing. We often find abnormalities with the immune system. But I am always very clear with people that just because we found their abnormality, it doesn't mean that that was the one thing that explained their entire reproductive history, that by fixing that one thing, everything is going to be perfect going forward. So it is more of a situation where like things haven't worked the way they were supposed to. I can only fix the things that I find. We've already done the cavity assessment. We have already done the lining assessment. We know that the hormones are normal. We have maximized the protocol. Now we're finding something else with the immune system, and we're definitely going to take it seriously and we're going to treat it because we want to treat every single thing that we see in our path to get you to that successful pregnancy. But that's not the same thing as saying, hey, I found the culprit and now everything is going to be perfect. So I always spend the time making sure that patients understand that nuance.
Yeah, absolutely. I mean, immune testing, as I said, it's one piece of this big puzzle. And it's important to reiterate that when we see patients coming to us with recurrent implantation failure, recurrent pregnancy loss, we want to look at all the things and all the other causes as well. So, uterine factors, what's going on inside the uterus, lifestyle factors, possible silent endometriosis or occult endometriosis, and whether that could potentially be playing a role. We'll often talk about uterine microbiome and the uterine microbiome testing options, or chronic endometritis testing, the genetic testing of the embryos, and the limitations of genetic testing of embryos as well. And then knowing that there is still this wide swath of stuff that we just don't know about and that we don't recognize in terms of what's going on because our knowledge is still pretty rudimentary, unfortunately.
Immune testing is actually really close to my heart. We've been doing this at Markham Fertility Center for many years, more years that I've been here. I've been here for approximately 15 years now. And like I mentioned earlier, this is a program that Dr. Vero started in the early 2000s. And when I started working here, he was so passionate about it. And he taught me quite a bit about the immune system and immune treatments. And I started seeing with my own eyes. I was a skeptic because I came from training as a fellow in reproductive endocrinology when it was very much here's the box and here are the guidelines. And then I came, like I said, to the real world and worked with Dr. Vero and started seeing all of these patients that were having multiple euploid embryo transfers. And it was very difficult, if not impossible, to tell them to just keep transferring embryos. So as much as I respect the studies and I respect the guidelines, I also understand that just because there isn't a perfect study and there isn't a perfect guideline, it doesn't mean that the evidence does not exist. It just means that we haven't found it yet. I know how hard it is to do really good studies and collect good evidence. In medicine, in the real world, sometimes we can't wait for the perfect randomized controlled trial in order to be able to offer our patients treatments with good education and good informed consent. So I believe in the immune program at American Fertility Center. We have a lot of experience with it. We have treated successfully many, many patients. We're continuing to collect data. We're continuing to learn. We're continuing to improve the program. And we will continue to offer it. Again, the foundation of our program is informed consent, choosing the right patient population, and being very, very clear with patients about the options, the risks, the cost, and the fact that they can always choose to keep transferring embryos and not do anything. And that is a valid choice that is supported by research and the guidelines. And it's a choice that we present to all of our patients when we're consulting for recurrent implantation failure. With that being said, this concludes our first episode of the Immune series. I hope that you took away from this episode that reproductive immunology is a complex, it's evolving science, and it is controversial. It's also a space where there is a lot of innovation happening, and with thoughtful clinical application in the right patient populations with the right discussion, it can help some patients achieve their dreams of a family.
And we really want patients to appreciate that we are not saying that this is a magic fix, and that we recognize and we're very aware of the controversies that surround these things and why they're not in the guidelines. And we want our patients to understand that as well. Because again, it all comes down to this shared decision making in terms of what we're going to do and how we want to move forward from where we are. That being said, we certainly have stories of patients who have come here, have done immune testing and then have done immune treatment and have had these incredible, amazing miracle stories. We both can think of many, many patients like that, but at the same time, we're very mindful that we don't want to offer false hope or to tell people that this is the fix. And so hopefully we've been able to strike that balance of informing you and sort of letting you know what's going on in our minds when we're thinking about immune testing and treatment so that you can appreciate how murky these waters really are.
So we're going to keep diving into the murky waters in future episodes. So stay tuned for part 2. We're going to go deeper into specific therapies, such as SCIG and intralipids and lymphocyte immunotransfusion. Thanks for listening and see you at the next episode.
And that's a wrap for today, Superhumans.
If you're looking to connect, get social with us. Follow us on YouTube and Instagram at My Fertility Podcast or visit us online at markandfertility.com. And don't forget, follow, subscribe, and share your favorite episode.
Thanks for listening to My Fertility Podcast and for being a vital part of our community. We know you've got this.
We're signing off until next Tuesday.
If you found this episode of My Fertility Podcast helpful, please take a moment to head over to the review section and leave us your thoughts. Your reviews and comments are incredibly valuable to us and help guide future episodes. We also welcome you to direct your questions to info@myfertilitypodcast.com.
My Fertility Podcast is produced by Rabbit Media Inc. in conjunction with Dr. Garcia and Dr. Weiss.
Music from Mixkit, Life is a Dream by Michael Ramir C.
My Fertility Podcast is not intended to replace any type or variation thereof professional medical, health, or legal advice, nor should the content be taken as medical advice. Please contact your primary healthcare professional regarding any medical questions you may have. The information presented in this podcast is based on the knowledge and understanding of the host at the time of recording. Medical knowledge is constantly evolving and and new research may change the understanding of health-related topics. While we strive to provide accurate and up-to-date information, we do not guarantee the completeness, accuracy, or timeliness of the content. The views expressed in this podcast by guests are not those of the host or the management. This podcast is not intended to impose any type of discrimination. My Fertility Podcast and its management are not responsible for any losses, damages, or liabilities that may arise from the use of this podcast.